too much of your time. I understand that you're all here to hear Dr. Gray's wonderful presentation. I think the second time that I've had the pleasure of listening to it. I just wanted to very briefly speak about a couple of the software innovations that we're working on here at Caliacon, and Caliacon's a partner business of Medico Legal Assessments Group. And I specifically wanted to talk about some of the work that we're doing in our artificial intelligence and machine learning space. One of the tools that we're working on is an artificial intelligence tool for surgical quotes, which is assisting insurance agencies and specialists with medical billing and invoice approval, especially where the compensation scheme may be quite complex and quite complicated. We're working with some specialists, some trading specialists, and some of our clients in the insurance industry to assist them in smoothing out that billing process, especially as recent judgments by the AHPRA do highlight the need for correct billing. And these are convoluted and complicated compensation schemes. So we've developed a dual use tool for specialists and insurance agencies to check these surgical quotes, make sure they match up against the AMA guide, that they match up against all of the relevant loadings, et cetera, So really increasing compliance in the industry and decreasing the time required for approval, which means that the worker can have their surgery done a lot faster and can return to work in a more expedited fashion. One of the other pieces of work that we're doing here at Caliacon is our state-of-the-art data analytics and machine learning. And so we assist law firms with their compensation decisions by providing access to trend analysis of compensation, impairment, treatment decisions across all jurisdictions. So we can support law firms and insurance agencies to make these decisions with high quality, compliant data analytics that allow them to see trends in compensation over a long period of time. Some of the other things that we're working on, we're working with some of our clients in the legal industry and the government agency and the regulator space, and with some independent specialists to provide a software solution to key stakeholders across various sectors. And all of these platforms include state-of-the-art data security and compliance aspects. And in addition, we're working on some other artificial intelligence tools specifically around financial calculations and claims leakage, and we've got some integrated telehealth solutions as well. Look, that's all I wanted to touch on for today. We might follow up with some information over the next couple of weeks, but I'll hand back to Michelle and Dr. Gray. Thank you very much for your time.
Thanks, Lockie. Certainly very exciting for us, what we're bringing to the market for everybody. So I hope that you get to take advantage of some of that. Now, Dr. Gray, you can share your screen back again.
I would love to. Where's the share screen doodad?
Down the bottom of your view, it's a green.
Share screen, yes, got it.
Yep, that's the one. So, everybody, I'd like to introduce to you the very lovely and very handsome Dr. Peter Gray. Dr. Gray is an orthopaedic surgeon, and his talk today is about knee injuries in the workplace. Dr. Gray has an absolute wealth of experience in hips and knees in particular. He was at pioneering stages of things like arthroscopy and arthroplasty, knee reconstructions. He's even done a fair bit of pediatric orthopedics. He has special areas of expertise in relation to trauma and has a number of very senior hospital appointments under his belt as well. Dr. Gray's been with MAG for such a long time that his doctor ID is only 3 digits. Most of them are 4 digits. That gives you an indication of just how long this wonderful guy has been with us. And he doesn't look a day over 26 or 27, as you can see. Now, something that you might not know about this man is that he is actually a beekeeper. So he, I presume, makes his own honey for the family table and possibly, sells it on a little stall at the front of his property with an honesty box for people to put it in. Don't know, how interesting his honey gets, but I look forward to hearing all about that. So before I leave you with Dr. Gray, I will leave you with a dad joke. What is the last thing that goes through a bee's mind before it hits the windshield? Anybody? It's stinger. Over to you, Dr. Gray.
Thanks, Michelle. Well, good morning. Well, actually, good afternoon. So as Michelle said, look, I have an orthopedic career. I'm an orthopedic surgeon. And my career ambition was to look after conditions of the hip and knee from the cradle to the grave. Not mine at this stage yet, but the patients under my care. I think to a large extent I achieved that ambition, but I ceased operative orthopedics at the age of 65 some years ago. But I've continued to work as an IME, and I deal only with cases of the hip and knee, which I regard as my area of expertise. So today, slightly different to a talk I've given previously, but including some of that, I thought I'd center my discussion around a case that I recently saw. And this is a 51-year-old male firefighter who's been in the service for 20 years. He had sudden onset of right knee pain and swelling at the bottom of a flight of stairs in the fire station 2.5 years prior to my seeing him. There was no reported twist or fall. He had an arthroscopic procedure in December of 2012, and this is sort of what it might have looked like, a bit of poetic license here, but nonetheless, it's similar to the one that I saw in his file. And and what you see here, this is bare bone. This is exposed bare bone, and just through here, there is a meniscal tear. And if you put a probe in that, you'd pull this forward, it'd be unstable. Anyway, the surgeon at the time, not me, decided to remove that meniscal tear, exposing more bare bone. So that's sort of, want you to keep that in mind as I proceed to the rest of my talk, because really the crux of my talk today will revolve around my responses to the questions that I was asked. And typically I get asked questions like this: has the worker sustained an injury arising out of or during the course of their employment? Pretty typical question. And then are the symptoms entirely related to the incident, and how much of their current presentation do you attribute to a pre-existing condition, a previous injury, subsequent events in their life and lifestyle activities? Now, when assessing this case, you've got to take a number of things into account. And obviously you need to take a history. You need a good clinical examination. And this is one of the reasons why I'm not keen on doing telehealth. In fact, I won't do it, because the physical examination is all important, and you really can't examine an orthopedic problem without actually feeling the knee, seeing what it does. If it doesn't move, why it doesn't move, is it loose, why it's loose. And so I'm very uncomfortable with telehealth, and I'm not going to do it. Anyway, so you also need access to good clinical records. Unfortunately, in this case, we had good clinical records. And you also need access to quality imaging studies. And on this aspect, I'd like to, anybody, if I get sent any work, and that's your choice, not mine, please make sure the patients know they should bring in their x-rays. I want to see the films. I don't want to read reports, because I want to physically see the films. I want to check the films. I want to make my own measurements. I want to make my own conclusions and not be guided by the reports. In my opinion, there are about 3 really good radiologists who report MRI scans, and the rest dabble. Unfortunately, we used to have meetings regularly with those 3 men, and I learned a hell of a lot. I'm not always right, but I know a lot more than I used to. So I really need to see images. And then you also need an understanding of the structure and function of the knee, and that's clearly what I learned in my training. And an understanding of the natural history following the injury. And again, that's what I learned from experience. Right, go forward. Oh, I have to come down here. Sorry, folks. Ah, okay, so the knee joint. So the knee obviously provides mobility and dynamic support during dynamic and static activities. And clearly you need a good knee to do what these blokes are doing. So it supports during weight bearing, but it's also mobile during non-weight bearing. And, just getting in and out of a car, even lying in bed and curling your knees up in bed, you need a comfortable knee to do that. So really it's involved in almost any functional activity of the lower extremity. And it's very important, and people don't like it when it's not working. And just briefly, you got the knee joint down here. At the front of the knee, you've got the big quadriceps muscle, and that flexes the extended knee. And at the back of the knee, you've got these big hamstring muscles, and they flex the extended knee. Now, the knee is an interesting joint because the articular surface of the tibia is much shorter than the articular surface of the femur. So the knee, when it flexes, it not only has to flex, it also has to roll forwards. So if we look here, this is, we've got 1 and 2 marked here, and this is 0.3. If it was a hinge, this would just drop off the back. But when the knee flexes, 0.3 comes in contact with 0.2. So just in another schematic way of looking at this, so you have both this roll, but you also have this glide. So as the knee's flexing, it's gliding forwards. And the thing that controls that movement are the ligaments. You need you need your anterior and posterior cruciate ligament, and you need your collateral ligaments. And when they're injured, this mechanism gets mucked up, and that creates its own issues. And we'll talk about that later on. So just briefly looking at the knee joint, we have here the articular cartilage, and this is the smooth lining that covers both the femoral side and the tibial side, and also on the back of the patella here. In addition, we have the menisci, these little discs of gristle, the one on the inside, the medial one on the outside, the lateral one. We have a medial collateral ligament over here. We have a posterior cruciate here, which goes from the back to the front, and an anterior cruciate ligament here, which goes from the front of the tibia to the back of the femur. And over here, we have a lateral collateral ligament. So just looking at the articular surface, so this is this smooth lining over the covering the bones. And this provides a smooth, lubricated surface for articulation and facilitates the transmission of loads from this rigid bone to this rigid bone. And this bearing has an extremely low coefficient of friction, and it's lower than glass on ice. So if you get a piece of ice and move it across glass, there's no grab at all, and this is far lower than that the coefficient of friction of that activity. Okay, so what is this structure look like? This is a schematic representation, and it's just important to understand this a little bit. I won't bore you too much, but I quite find it fascinating, and if I find it fascinating, you'll have to hear about it. So the articular cartilage is comprised of 3 structures, and we'll come to this third one in a minute, but 10 to 15% is collagen, and these are these bands that run up here. These form arcades, a mesh of arcades that go from the bone up to the surface of the articular surface and back down again. And these are repeated over and over and over again. Now, these bands withstand tension, but they don't stand compression. They don't like compression. And in amongst this is this pink stuff, and this is a gel. This is a mixture of proteoglycans and 80%, 10 to 15% proteoglycans, 70 to 80% water. And this makes up a gel, and it's a bit like the gel in the back of your ASEC gel runners on the heel bone, on the heel of the shoe, of the sole of the shoe. So it's very compressible. It really withstands compression, but it doesn't withstand tension. So you can imagine you've got this gel in here, and throughout this gel are these multiple bands. So when a load comes down here, the gel supports the load, but the gel wants to squish sideways, but it can't squish sideways because these bands are stopping it moving sideways because they're resisting tension. And this is a really incredible structure. And it's really capable of transmitting great loads. And just getting back to our case, walking down a stair, 4 times your body weight, or 4.3 times your body weight, is transmitted through that articular cartilage. So it's taking an enormous load. And also a point to note is if you're 10 kilos overweight, you're putting an extra 40 kilos on your joint that it wasn't designed to carry. Now, this articular cartilage looks pretty thick here, but it's only about 2 to 4 millimeters thick, depending on which joint. In a finger joint, it may be 1 or 1.5 millimeters. In a knee, it's probably 4 millimeters. But the back of the patella, which is the thickest articular cartilage, can be up to 5 millimeters thick. The other thing about articular cartilage, it's devoid of vessels and nerves. And because it's devoid of that, it has a limited capacity to heal and repair. So that's important. So once it's damaged, that's it. So this is just a close-up view of this articular cartilage. And these are the cells in the articular cartilage. They're the chondrocytes, very small volume of the articular cartilage. But these cells are responsible for the extracellular matrix turnover. So they make the proteoglycan. And they have limited replication, limited potential for replication. This is why articular cartilage doesn't heal. Now, the preservation of this articular cartilage is really dependent on maintaining this organized structure. And sadly, this organized structure becomes disorganized when we have injury. And that's the sort of thing we're going to talk a bit about. So here we see, this is the back of a kneecap. And this is big slabs of articular cartilage which have sheared off this kneecap. And if we look here, we can see that there are little grooves in through this cartilage. This is the articular surface, and the backside here is where it was attached there. So prior to this event happening, there was something going on in this knee. This articular cartilage was getting disorganized. Proteoglycans weren't as good. The collagen wasn't as good. So given a significant shear stress sideways, this all just sheared off. Now, this is a rather dramatic picture of what's going on, but oftentimes it's just these little bits, these little fibrillar bits here that break off. And when these bits break off, they're irritating to the knee, so, and particularly the synovium. So the synovium sets up an inflammatory response, and you get release of all these inflammatory cytokines, which do all sorts of nasty things. And part of those nasty things is just to destroy articular cartilage. So, and that's why one of the main signs of a problem with a knee is that it's swollen. Two things will swell a knee. One's blood, and that'll swell and it will come up really quickly. So if you tear your anterior cruciate within half to 1 hour, your knee's full of blood and it's very painful. But if you do something like this, it'll be sore when you do it, and over the course of 24 hours, it'll swell and you'll start to get an effusion, and that's synovial fluid, not blood. And normally there's only about 0.2 mils of synovial fluid in the knee. The rest of the time it's it's not angry and quiet and just ticking along nicely. Okay, so moving on, we have the menisci, and these are these little discs of gristle on either side of the knee. So you've got the medial one, the lateral one. Just a couple of things to note. The medial meniscus is well tethered to the capsule all the way around here. The lateral meniscus is attached to this popliteus tendon, so that when the knee flexes, the popliteus muscle pulls this back of this tendon out of the way so it doesn't get squashed. So in the normal course of events, more injuries occur in the medial meniscus because of the tethering than occur in the lateral meniscus. So what does the meniscus do? Well, it has primary and secondary functions. It improves load distribution by increasing the area of contact, and I'll show a schematic representation of that. It also increases the stability by cupping the femoral condyle, and I'll show a schematic representation of that. But it's shock absorption too, as I've, in addition to the articular cartilage. The menisci also take a lot of weight, and so a skier jumping from a landing and all those guys doing those acrobatics at the Olympic Games on skateboards and bikes, they're putting enormous forces through their knee when they land. So they'll be with us in the future. It's one good thing about sport: there's always work. The other thing is it's very important for nutrition, because it's the synovial fluid is between in the joint, and it is swept along by the meniscus and the articular cartilage. So it then allows for nutrition, which is in the synovial fluid, to get into the cartilage, because that's where it's getting its nutrition from. Okay, this is just to show what I mean about distributing the load. See, the femur, as you saw in one of those earlier slides, is convex, and the tibia, this convex, and the tibia is also convex. So you've got these two surfaces. So if there was just this, you'd have a very small area of contact. but the meniscus fills in the gaps. So you get a far bigger area of contact. So the load is distributed more evenly across the joint, and you don't get point loading because force is related to area. So the smaller the area, the greater the force. So when the meniscus goes, you're getting concentration of the force in one area, or more concentration of force, shall I say. And also you can see, because it cups the femur, it also provides some sideways stability and fore and aft stability as well. So it does enhance stability a bit too. So it's pretty important. Oh, very important. I love this diagram. When I first saw this years and years and years ago, I was fascinated. This is India ink injected into the genicular artery, and it just shows how much of the meniscus, this structure here, has a blood supply. There's no blood supply in this part here, and therefore if there's no blood supply, it can't heal. Here it can heal, here it's going to heal. And so meniscal repair is undertaken in an area here where you've got a bit of blood, and so there's a chance that if you stitch this, this will heal. But if you tear it out here, it's not going to heal. It can't. There's no way it'll heal. Other thing about the meniscus is, again, it's an incredible structure. No man-made structure can look anything like this. You know, this has these collagen fibers. They run horizontally, they run vertically, they run tangentially, they run diagonally, and there's this big mesh of these collagen fibers all coming together to create this structure, which is really, really resistant to forces most of the time. Okay, but menisci are vulnerable to injury, and particularly vulnerable when subjected to a twisting moment on top of a compressive force, and typically on a flexed knee. So it's not surprising that in these sports we see people have knee injuries. But, you know, why? How come this man played 148 test matches for the All Blacks, and he was no shrinking violet when it came to getting into play? And I dare say, once this guy hits the ground, he will be on top of that ball and he'll get it back to this bloke in a nanosecond. Now, this bloke, on the other hand, he's torn both his posterior cruciates in sequential injuries. So why did he tear his cruciate? And this fellow has been relatively injury-free. In fact, I've only been able to find one occasion where he was out of the game for about 6 weeks with a medial ligament injury, but he didn't have surgery. So what is it that makes him so special over this bloke? And the answer is collagen. So he has good collagen, and he doesn't have such good collagen. He's got bad collagen. Well, not bad, but it's not as good as this bloke's collagen. He's got great collagen. And I had the good fortune during my career to be trained and work with a man I greatly admired, Tom Taylor. And he was heavily involved in research, and particularly collagen research. And he called collagen the prince of tissues. Now, I didn't know then what a wise man Tom was. And he was much wiser than I thought, because he knew there were good princes and bad princes. But I shouldn't talk about Andrew because he's facing legal action. I might get into trouble if I proceed while I'm talking in this forum. Anyway, moving on. So how do we diagnose these meniscal tears? Well, a good way is with MRI scans. And here we can see there's this little linear high signal through here, but you know, an MRI scan is really just showing us a static image. It's not dynamic. We don't so it's just seeing lines on a page, so to speak. And oftentimes these are reported as tears. Well, it might be a tear, but it might just be a defect in the meniscus. The only way to find a tear is to stick a telescope in the joint, and this is a probe. This is the meniscus. This is a probe hooked around that tear, pulling it forward. And we can see that this is now unstable. And as Michelle said earlier on, I was very fortunate to start my career when arthroscopy was in its infancy. And we started off just doing diagnostic arthroscopy, and then we had instruments and we could do therapeutic arthroscopy and surgical arthroscopy. And I must admit, I was enthused by this procedure, and I did many. And I did many before MRI came along. And MRI scans enabled us to see inside the knee without actually looking inside the knee. But we didn't really know, how do you relate this to this? And what does this mean? And so it wasn't until after many MRI scans and many operations that we now know what this would look like if we did this. And so that now we're much less likely to do this because we've got this. And Mark Gibbons always likes this story, so I better tell it. I've got time. I don't want to waste too much time. But many years ago, when I thought I was a bit of a hotshot, I was invited to give a talk on diagnostic imaging in the assessment of the acute knee injury. And it was to a very august group of radiologists who were the musculoskeletal imaging group, and they were all the top guns in musculoskeletal imaging. And I was a brash young man, and I got up there, and at this stage I think I'd seen about 3 MRI scans. We didn't have them. We had CT scans, we had ultrasounds, we had nuclear medicine scans, and I spoke all of that. We had arthroscopy, we had our hands, we could look and see, we had x-rays. So I thought, and I made the comment that I saw no place for MRI scans in the assessment of the acute knee injury. And, you know, I never got invited back to give that talk again. And sadly, but you learn a lot. You know, you never want to think you're too smart, because now I think the MRI scan is a fantastic tool, but it's not the only tool. And there is still an enormous role to be played by X-rays, plain X-rays, particularly weight-bearing X-rays. And you know, weight-bearing, and I would not have done an arthroscopy without a weight-bearing X-ray. They all come with an MRI scan, but I used to get an X-ray before I did the operation, because I like to see what's going on. You see a lot on a radiograph, and in fact, when it comes to whole person impairment, there is no rating in whole person impairment for whatever you see in an MRI scan. You can only get a rating from a plain X-ray looking at the joint space, and you only get a look at that joint space on weight-bearing radiographs, not an MRI scan. Sure, you can see the articular cartilage. Where's my arrow? Sure, this is the articular cartilage from there to there. You can see that, and you can see if it's worn, but it's not the same as getting a weight-bearing radiograph and seeing how close that bit of bone is to that bit of bone there. Okay, so however, you know, this meniscectomy business is not benign, and we now know that you know, there's a almost 16% conversion rate to total knee replacement at 20 years after partial medial meniscectomy. And this is a pretty typical example of what happens. There's a series of radiographs taken at 7 years after the operation, and already this medial joint space is starting to deteriorate. 13 years, not much of a change, but we're starting to get some osteophytes appearing here. And by 21 years, this joint space is almost obliterated. And this is why I like radiographs. If you look at this knee on the MRI scan, it may not look as bad as it really is. And sometimes I've seen plain X-rays that look normal if they're not, particularly if they're not weight-bearing. Yet when you do a weight-bearing radiograph, you see that these two bones are opposed. So we just want to stress the importance of weight-bearing radiographs. Okay, so predictors of poor outcome following meniscectomy: female, sadly, older age, degenerative tears, malalignment. So if you've got a medial meniscal tear and you're bow-legged, you'll very rapidly get arthritis on the inside of the knee. And likewise, if you've got a lateral meniscal tear and you're knock-kneed, you'll get rapid onset of arthritis. Obviously, if there are chondral lesions, like I showed with that fracture, and being overweight doesn't help. And, you know, the people I hated seeing were middle-aged females who were knock-kneed, who had a torn lateral meniscus, because there was just nothing but sadness to follow any intervention in that particular case. Okay, so post-meniscectomy. And this is why now, you know, when I started out, we didn't have all this information. We didn't have MRI scans. We had this new procedure that was exciting. It was a low morbidity, a low surgical morbidity, and we thought we could cure the world with the arthroscope. But this is a recent paper out of Sweden, because the Scandinavian countries have fantastic data to make these conclusions. Anyway, they had 140 middle-aged patients with an MRI scan verifying a degenerative meniscal tear. And this was the 5-year follow-up. Half of them were treated with arthroscopic meniscectomy and half were treated with therapeutic exercise. There was no difference in radiographic progression between the two groups. And there was no difference in patient-reported outcomes between the two groups. Now, as a surgeon, this comes as you know, painful news, that this is just as good as this. But sometimes we just had to accept these things. And this is the clinical challenge that we find as clinicians, is it's difficult to discriminate between symptoms caused by an MRI-defined meniscal lesion and the symptoms of early-stage osteoarthritis. And this is difficult, and that's probably why we recommend surgery, but not always get the outcome we desire. Okay, moving on. So just quickly, where's my arrow? Sorry, folks, here it is. Just to talk about the ligaments, posterior cruciate ligament, anterior cruciate ligament. I'm not going to talk about the collateral ligaments. That could be a talk for another day. So posterior cruciate ligament tears. The incidence is 2 per 100,000. Far less than the incidence of contracting a clot with AstraZeneca. And this is often missed on a clinical examination. And when you flex the knee up to 90 degrees, you can see this is the other knee, and that's what it should look like. On this knee, you can see this tibia's drop back. Now, this is quite a significant posterior cruciate tear, but oftentimes with an isolated posterior cruciate tear, the knee looks like that. So if you don't pull this, if you don't assess this knee, there was a thing called the anterior draw, where you pull, you get on the tibia, you pull the tibia forward and you feel the tibia come forward. And that was said to be evidence of an anterior cruciate ligament tear. But over time, we found that not to be as reliable as a thing called the Lockman's test, which is a similar procedure performed with the knee only flexed at about 20 degrees. And because of that, the anterior draw, no one did the anterior draw. But if you don't do the anterior draw, you won't do the posterior draw, which is when you push it back. And so why I tell the medical students, look, I know the anterior draw is not that clinically relevant, but if you don't do the anterior draw, you won't do the posterior draw and you will miss this sign. And that's very, very important because it's often missed. And the thing about the posterior cruciate is it's often asymptomatic following rehab. You know, Ma Nonu, the guy I showed earlier with the bilateral posterior cruciate tears, he continued to play many test matches for the All Blacks without posterior cruciates in either knee. And I saw prior to the Sydney Olympics, I saw a fellow who had bilateral posterior cruciate tears who was the Australian 110-metre hurdle champion. So it just goes to show you can do a lot. But this is what happens. Unfortunately, I have all these people down here obliterating this side here. But anyway, the natural history. So 13 years after 13 years after a cruciate ligament tear, there's about a 20% incidence of meniscal tears. And PCL insufficiency increases the likelihood of articular cartilage degeneration over time. So it's not uncommon to see in people who have medial compartment osteoarthritis to have had an old posterior cruciate ligament tear. And move on to the anterior cruciate. So this is a far more common injury, 70 per 100,000. And it's seen in these sports, AFL in particular, netball, soccer and the rugby codes. And it's twisting on a flexed knee, but it's also landing from a height. And this is why it's very common in AFL. They jump up and they land and they tear their posterior cruciate. And the problem with the posterior cruciate tear is that unlike the anterior cruciate tear, the problem is that it gives way to symptomatic giving way, which is unlike the posterior cruciate, which doesn't give giving way. And just a representation on the MRI scan, this is where the cruciate should be. It's all white and blurred. And this is what it looks like. This is a probe pulling the cruciate. You can see it's all red and inflamed up here. And when you put a probe over it, this should be a nice straight structure straight down here. It shouldn't have this bend here. So that's gone. And this is why I think MRI scans are brilliant. we didn't know about this. When I first started doing cruciate ligament reconstructions, we didn't know about this particular injury. So when you're looking at MRI scans, you go to the black slide, pretty simple. You go to the black slides and you look on the black sides to see if you can see white where there should be black. So here's white where it should be black. And here's white where it should be black. So this is abnormal. This is a bone bruise or an infraction injury. It won't show up on an X-ray, but it shows up on an MRI scan. And if you look at the curve here, you'll see how neatly it fits into the curve here. So with an anterior cruciate ligament tear, when your knee gives way, this lateral femoral condyle flops over the back of the lateral tibial plateau, which is unsurprising then to realize why it hurts so much. Because that, this is quite a big movement in the knee. And also you can see that this smooth surface is no longer smooth, it's now got this bump in it. Now, between that infraction injury and the meniscus is the articular cartilage. So for this to occur, the articular cartilage must have taken a hammering. But not only that, as this flipped over the back, this has dragged the lateral meniscus backwards in a movement that it didn't like. Sure, it's got some mobility, but not the amount of mobility that this is inflicting on it. And that's why you get lateral meniscal tears. So the point is that in an anterior cruciate ligament tear, 80 to 90% of them have this bone marrow edema. And that damages the chondrocytes, which damages the proteoglycan, which damages the collagen and the alignment and orientation of these collagen fibers, and then you get articular cartilage disruption. And 25 to 60% incidence of associated meniscal tears, if not on the acute injury. If you don't fix these injuries, you will have repeated, every time your knee subluxes, you run the risk of damaging your menisci. And don't forget, there's two compartments. So as this falls over the back, on the other side of the knee, the medial side, it's rotating. And it's rotating and putting a force on a meniscus that doesn't want to move because it's attached all around it. So it then puts stress on that and can lead to it tearing too. So this is a 2018 meta-analysis of 41 studies, again from Sweden. It's a huge study. I mean, it's just remarkable what they've been able to do. But the point of it is that in an isolated anterior cruciate ligament tear, 13% of people can get arthritis within 10 years. And if you've got both an anterior cruciate ligament tear and a meniscal tear, anywhere between 20 and 40% will develop arthritis within 10 years. The other interesting thing about this paper was there was a weak correlation between the degree of radiographic changes and the severity of the pain that patients experienced. And oftentimes we see people who complain of enormous amount of pain with essentially normal looking x-rays. And likewise, you see people who just shouldn't be walking around on their knees who don't even know they've got a problem. Well, they know they've got a problem, but they don't complain. So, and this is the difficulty with the clinical aspect of this work. Okay, so quickly, let's get us back to our firefighter. So he injured his right knee. He injured his right knee in the army because I had notes which demonstrated in 1990 he had an injury that was treated non-operatively. But back in 1990, people probably didn't diagnose the posterior cruciate. He continued to participate in the commando unit since discharge from the army. And he was seen by a sports physician in 2002. And it was noted that he had PCL laxity at that time. And there'd been no history of, despite all this activity, there'd been no history of any other injury other than this. So I'm quite happy to accept that he tore his posterior cruciate back here. And he just had ongoing problems for the reasons I've already discussed. He had that arthroscopic surgery in 2012. So what, 22 years later, he's already got arthritis in his knee. And then, unfortunately, they took out the meniscus, so that didn't help either. And he consulted an orthopedic surgeon in August of 2014 because he had knee pain, but it was decided he didn't like the various treatment options at that time, so he just put up with it. And then in February of 2018, walking downstairs at work at the fire station, his knee was painful at the bottom of the stairs and soon became swollen. So the questions I get asked, are the symptoms entirely related to the incident? Well, then how much do you attribute to a pre-existing condition. Well, in this case, I'm quite happy that he tore his posterior cruciate, and as a result, then something happened, and he then had a meniscectomy, and so the arthritis that he had, I'm pretty happy, was due to the fact that he tore his posterior cruciate, had a subsequent meniscectomy, and that was just what happens in that situation. This is always interesting. There's subsequent events in their life and lifestyle activities. Now, you know, I often we get asked, you know, there's oftentimes, you know, we'll just take an example, a truck driver working as a truck driver, long haul truck driver, 40 years, multiple times getting in and out of the truck, crawling under the truck, jumping down off the tray, but no specific injury. And they say, well, clearly, you know, doing all that hard work all that time caused his knee to wear out, and that's why he needs a knee replacement, and the insurance company should pay for it. However, in the latest Australian Orthopaedic Association National Joint Replacement Registry, 57,189 total knee replacements were performed in 2019 in Australia. 57% were females, with a mean age of 68%. Now, in the past 50 years, women haven't been involved in heavy manual work. The times are changing. So you'd expect, if heavy manual work, per se, without injury, was a cause of knee damage and osteoarthritis, there theoretically should be many, many more men in that statistic than women. So there's something more, you know, so I'm uncomfortable subscribing, you know, just normal day-to-day events or part and parcel of what you do as causing the arthritis in your knee. I really like to see a specific injury to account for what's going on, rather than just, you know, you have a tendency for osteoarthritis of the knee. But there we go. Now, the next question is, has the worker sustained an injury arising out of during the course of their employment? And this I find a lot more difficult to answer. If you look at the Commonwealth Act, it says, you know, well, you can read what it says, but what it doesn't put at the bottom, it says, does not include a disease, injury, or aggravation suffered as a result of reasonable administrative action taken in a reasonable manner in respect of the employee's employment. Now, I would have thought that if, and look, I'm no lawyer, but if the stairs are in good condition and everyone walks up and down stairs, then this fellow's injury would not be covered because the employers have taken all reasonable manner of to prevent it. So in this situation, his symptoms relate to his arthritis, and that's the end of the story. That's in the Commonwealth. However, in the state, it says, so a disease that is contracted in the course of his employment, but only if the employment was the main contributing factor. Now, clearly, his work was not the main contributing factor in his osteoarthritis. You know, I've already told you, I think it's due to an injury years ago and just the time after that. And then it goes on to say, an aggravating exacerbation in the course of employment of any disease, but only if the employment was the main contributing factor to the aggravation. Well, if he wasn't walking down the stairs at work, he wouldn't have aggravated his knee. And I don't know, and I'm not, so I struggle with this, or an exacerbation or deterioration of the disease. And these are all different terms stating the same thing. So, you know, I find it difficult to know in this situation. He was walking downstairs doing a task at work and he developed symptoms, albeit from a disease which was not caused by work, but the aggravation was caused by work. And the other thing about this is that he's going to do this injury time and time and time again in the course of his employment as a firefighter. Now, he's only 51. He's not about to retire, and neither he should. So he's eventually going to need a knee replacement. And then is it up to the insurance company to bear that cost? I don't know. I'm not sure. However, that's my interpretation of the Act. So I don't make the rules, I'm just refereeing the game. And I really welcome comments from the audience as to how I should interpret this, because, you know, part of me says it shouldn't be, but I read this and he says it should be. So I have a difficulty answering that question. The other question I get is, and I'll just finish on this, please provide your opinion on ongoing liability of this claim. Well, if I look at this, the standards of practice and liability for medical or related treatment, when determining liability, insurers are to obtain and make a decision. So I'm not sure that I should be making that decision. I provide the information, but I'm not sure it's my role to comment on liability. And I put that up again because I welcome comment on that. So anyway, I hope that's been enlightening. If not enlightening, I hope you are calm. Thank you very much.
Thank you so much, Dr. Gray. That was really fascinating. I always enjoy hearing your talks. I found, just my own comment was looking at the fact that females are the greatest at risk for these knee injuries. I'm starting to think I need to get a wheelchair preemptively, given my advanced age. Although, interestingly enough, both of my sisters have had knee replacements and they're younger than me, and they played netball and I didn't. I found what you talked about, the early incidence of MRIs versus X-rays, and then your change of opinion about the value of MRIs and looking for the white where it should be black. I found those really interesting diagnostic commentary based on reports that I've read in this sphere. There's been a fair bit of comment from people. I'd like to open up. If anyone would like to ask Dr. Gray some questions or have any comments, please feel free. Now is your time. Don't all go all at once.
Crickets.
Sikandar Khan here. Thank you very much for this enlightening talk. Just talking about whether one should accept liability or not, I think it's a difficult question for the surgeons to answer that in view of those regulations. But in the case of this fireman, I think had it not been for him going up and down the stairs, this would not have occurred, the aggravation. So I would think that we ought to think that on the balance of probabilities, work would be the major contributing factor.
I don't know if you can hear me. Look, I agree with you. It is, but it just you know, seems I'm not sure is that what the Workers' Compensation Act was designed to do. But however, that's the rules, and that's easy. That's why I always like them falling out of cranes. I don't have a problem ascribing the injury to the event. But yeah, look, I agree, and that's what I said. I said, you know, just that.
Yeah, that's good. Thank you.
Some might disagree with me, and I'm open to attack. I like
Tony Buzzard here. Liability is not a medical question, it's a legal question.
Yeah, that's what I thought. So what do I answer to that in future? I'd usually say it's not my purview to comment on liability. I've given you the information, it's your job.
Exactly. That's exactly what you would say. And indeed, often lawyers in particular will cross over those boundaries to see what they can get out of you. But all you can do is state your medical findings.
Yeah, well,
and then leave them to make the decision on liability.
I often get asked, so I'm only bringing it up in a forum like this because I feel more comfortable when people tell me what you're telling me. So I feel as though I can. Yeah,
it's actually really interesting. We had a talk with a lawyer a couple of weeks ago, Mark Rogalski, and he was talking about helping lawyers to write better letters of instruction and what doctors can and can't comment on realistically. And it's certainly something we need to get out there.
Mm-hmm.
John Garby speaking, Peter.
Okay, John, how are you?
Very well, thank you. Why is bone on bone so painful?
Yeah, good question, John, because as you know, there's no nerve endings in bone. And so it's intriguing to know why it is painful. But maybe there are nerve endings around blood vessels, and bone is fairly vascular. So maybe there are nerve endings in those tiny blood vessels which we haven't been able to find out. I'm not sure whether it's the pain that's coming from the synovium that's irritated, which is most likely, I guess. Yeah. So and that's the quandary. And why are some knees that look all right very painful, and some knees that look really bad aren't painful? And we don't really know the answer to that. I can't enlighten you anymore, sorry.
A follow-up question on another topic, if I may, please, Michelle. Did Tom Taylor do any work on replacing damaged collagen in joints?
No, they didn't. His main interest in collagen was with regard to scoliosis and why scoliosis occurred, and articular cartilage. But I think some of the work they did may have then, I mean, like all research, everyone stands on everyone else's shoulders, and that did lead to the development of articular cartilage grafting, which was quite popular in the turn of the century. But unfortunately, it was a very expensive process and fell into disrepute because not many people required it, and you needed big laboratories to facilitate that. And when the numbers that required it decreased, I mean, everyone tried to do it for everything, and it obviously didn't work. But there are specific cases where it worked really well. But those cases are few and far between. It's hard to justify a multi-million-dollar laboratory to grow articular cartilage cells when the requirement is pretty small. But I think his research helped in the development of that technique. Yeah.
Thank you.
Yeah. Peter, one more question about the role of stem cells in making the total knee replacement obsolete.
Yeah. Well, I could be very cynical and say things like, if I go and throw grass seeds on the road outside, why do I expect to be a lawn tomorrow after the rain? I could also say, I'm a bit worried if I injected stem cells into my knee that I might grow a kidney. It's interesting. A hell of a lot of this work has been done, and they're charging an enormous amount of money for it. And yet good, controlled, randomized papers do not exist. There are some papers that show that people with the grade 1 and 2 arthritis, very early fibrillation wear in their meniscus, will get some pain relief with PRP injections and stem cells, or PRP in particular. But stem cells, look, I just haven't seen the literature that I can support it. And I make these comments and hoping that someone will send me a paper that will tell me that I'm wrong, but no one's yet sent me that paper. If there's a paper out there, send it to me. I'm happy to look at it.
Thanks, Peter.
Peter, while you're just there, I'll just briefly interrupt. We've had a couple of comments come through on the screen from Brian Briggs. He says the reasonable administrative action is not interpreted in the way that you discussed. He says it deals with disciplinary matters or being directed to do things or administrative decisions in the course of employment. So that was interesting. We've had some comment on the Victorian Act, which says that it only operates as a defence in a mental health injury.
Mm-hmm.
And then Brian Briggs again says, thank you again, Dr. Gray. I would suggest if any of the doctors have questions about liability, it would pay to make a call and see how the acts are interpreted in the case. In the case of the fireman, it could be accepted that for his military injury and then an aggravation under the SRCA for his Commonwealth employment post-service.
Oh, he's covered by DVA. He's already got
exactly.
And when you've got two insurance companies, they'll fight that out between them, and I'm sure DVA is going to pick up the tab.
Good on DVA. Look, that was just terrific. Thank you so much, Peter. To everybody, we will share the slides with you, and the recording should be available for people to view within the next couple of days. Are there any further questions? No. All right. Thank you all so much. Have a great rest of the day. And thank you once again, Dr. Peter Gray.
Thank you.
Bye.
Thanks, Peter.
Okay.
Thanks, Michelle.